And without further ado, we'll introduce our first presentation for the day. A case of HLH in an adult patient. And our presenter is Dr. Luke Aaron. He is a microbiology registrar based in Cairns, currently pursuing dual specialty training in infectious diseases and microbiology. He previously served as an infectious diseases advanced trainee at the Gold Coast and Princess Alexandra hospitals. He is passionate about the efficient use of MDTs in routine patient care and the provision of quality medical education to students and junior doctors. So here we have him. Thank you.
Hi, everyone, and thanks for the introduction. I know we're already running over time, so I'll try and get through this as efficiently as I can. So our gentleman that we're going to speak about today is a 53-year-old gentleman who was transferred to our hospital last year for the investigation of a SIRS response query cause. This happened on the background of a liver transplant, which was done 6 months prior for combination alcohol and metabolic associated liver disease. And at the time that he presented to the PA was on single agent tacrolimus for his immunosuppression. His post-transplant course to date had been reasonably straightforward. He'd had some possible CMV disease a few months prior to catching up with us and had a less than 50% biliary stenosis that was stably managed on URSO. He came to us after having several admissions over the past 7 to 8 weeks to a regional hospital with a relapsing remitting fever syndrome that was associated with cytopenias. He'd come in, get put on broad spectrum antibiotics. Nothing would be found on the extensive workup that you can see on the table up there. And ultimately got transferred to us for further workup to try and identify the cause of his SIRS response. He was born in the UK, moved to Australia in the late 1970s, had spent 15 months in Saudi Arabia in the mid 2000s, but otherwise did not have any significant exposure history. He was previously living in Sydney, that's where his transplant was done, and he moved to regional Queensland shortly after his transplant to live with family. And as you can imagine, this introduced some complexities with trying to work out his risk profile, so it was very difficult to get access to his pre-transplant screening, and also information about the donor, of course, for donor-derived infections, introduced some complexities to finding out his risk profile. When he arrived at PA, he basically started from scratch. He was still getting fevers up to 40 degrees when he arrived at our centre, and he had initial blood tests showing, as you can see on the screen there. He had a CT chest abdo-pelvis when he arrived at our hospital that was pretty unremarkable, except for some mild hepatosplenomegaly. Now, due to the picture here with the pancytopenias, a mildly increased AST, the hepatosplenomegaly on CT, and the fact that we found no other cause to date obviously started some alarm bells for HLH. So some further tests were ordered, which showed a ferritin of around 9,000 triglycerides of 3. So special call out to the hematology reg that got a call from me at 4:30 in the ARPO and managed to organise a bone marrow aspirate, which were fine for the next morning. Obviously, we're getting a talk later more in the details of HLH, so I only show this slide to show that our patient met a couple of the criteria for diagnosis of HLH, as you can see there. So the bone marrow aspirate did end up showing histiocytes and hemophagocytosis of mature granulocytes. You'll see there that I've highlighted the soluble CD25. That's not something that we had immediately, obviously. It's a send away test to Melbourne that ended up coming back at 46,000. It's a bit higher than the reference range, and his ferritin peaked at about 15,000. As often happens with these patients, we throw the kitchen sink in terms of diagnostics at them, particularly when we're a bit unsure about what the underlying risk profile is. And for interest of time, the diagnostic test came back, was a positive PCR for human herpes virus 8. It's important to know that this is not a test that's available locally, and it's not something that came back quickly. So this is a send away test for us to Western Australia, which obviously significantly increases turnaround times. And so with this result was not back until about 2 weeks into our gentleman's admission. It's important to note that serology is not available in Australia. We just have the PCR assay. But this was likely the driver of his presentation, which I'll try and get into just in the last couple of minutes that I have with you today. So human herpes virus 8 is part of the gamma herpes virus group, which also contains Epstein-Barr virus. And similar to EBV, it's a double-stranded DNA virus that characteristically lies latent within inside lymphocytes and can drive lymphocellular proliferation, similar to post-transplant LPD. It's predominantly a opportunistic infection in the setting of significant immunosuppression, classically in AIDS patients, but asymptomatic infection in the immunocompetent can occur. It's not endemic in Australia, so Australian seroprevalence is around 5 to 6%, but is quite endemic in the kind of south to east in Africa, some parts of the Amazon basin, as well as southern Europe. HHV8 infections in transplant patients have been well described since the early 90s, and they can cause a number of different syndromes. But what we're going to talk about is just the bottom one there, this KICS, which is a primary HHV8 infection, which leads to an overwhelming immune response. This is a relatively recently described condition that was first described in this paper that's from only about 15, 20 years ago. And it is a condition of an overwhelming cytokine profile similar to multicentric Castleman's disease, but without any lymphadenopathy. Of note, the part of the diagnostic criteria is a plasmacytosis, and our patient did have a grossly abnormal serum protein electrophoresis that would be in keeping with this. I think the last line is quite interesting, as it basically describes HLH. And there's probably an overlap in these conditions, and further research since the initial description of this disease shows that these things probably exist on a spectrum. I'm not going to delve into the realms of treatment evidence today because, as you can probably imagine, evidence is not much. There's some case reports and expert opinion. So if you're interested, I direct you to this paper here. It's really lovely, that was written last year by Dr. Priya and a group out of Imperial College London. Well, what did we do? So as I kind of mentioned before, is we didn't have the HHV8 results until quite late in the presentation. So this patient was treated as a secondary HLH of uncertain cause with an anakinra backbone therapy with help from our hematology and immunology colleagues, and unfortunately passed away after 17 days in hospital. The other important aspect to his management, obviously, was notifying the New South Wales Transplant Service of the HHV8 result for the benefit of the other transplant recipients. And TSANZ was really helpful with this, and also involved contacting individual clinicians so that the 2 kidney transplant recipients and the heart transplant recipients could all be screened. And some of those patients have subsequently developed Kaposi sarcoma secondary to HHV8. Last content slide for you today is just to quickly talk about screening for human herpes virus 8, which is of interest and has been discussed before. There have been proposals in the UK to roll out universal screening for HHV8 for deceased donors. That's still, as far as I know, not yet to be implemented. So most of the data we have is from single centres. Particularly, the largest data set here is from the Institute of Transplantation and Advanced Specialised Therapy in Italy, who have been screening since 2011. And this is a nice little summary of their data that they published last year. And I'd just like to direct everyone to the bottom left-hand side of that, which shows that obviously the donor-positive, recipient-negative patients are at highest risk, but particularly the liver transplant patients seem to be at high risk of developing this inflammatory cytokine syndrome. So closing thoughts today, obviously HLH and associated syndromes like KICS are rare and can be difficult to diagnose. So we need knowledge of these conditions and a high index of suspicion, which is one of the main reasons that we're presenting this case today. Also, interstate transplant recipients introduce some extra complexities in care because it is really difficult to get the information that we need about baseline risk factors. So it's important to continue to develop our networks across state boundaries. And obviously, there's the importance to notify all those involved of any donor-derived infections in order to institute appropriate follow-up and management of other organ recipients. HHV8 screening is interesting. We currently don't have serology in Australia to do this, and there's limited data at the moment regarding benefit, but watch this space. Special thanks to Lana Sundak, ID physician heavily involved in this case and helped with the presentation, as well as Dr. Goran Ranagar, who are other ID physicians involved, as well as the other teams at PA who helped with the benefit of this patient. Thanks.
Thank you, Luke. If there's any questions for Luke from the floor or online, we can take them now. If not, we can give people some time to think and regroup for questions at the end. So thank you for that presentation. Definitely important to keep in mind. Not something at the forefront of our mind when we see patients that present with a HLH picture.